Now I have the pleasure of introducing Nancy. Nancy is renowned for her collaborative work on FASD-related research, training, and policy initiatives with the local, provincial, and national governments and organizations. Since 1996, her work with the BC Women's Hospital and the BC Centre of Excellence for Women's Health has focused on policy and service provision for women with substance use problems. Please join me in welcoming Nancy.
Thanks. Hi everyone, it's really a pleasure to be here today, and hi to all of you in other locations across the province as well. I hope you're going to enjoy this little exploration today of what we mean by trauma and its impact on health and its connections to substance use and its connections to the prevention of FASD in particular. I'm going to look at some of those connections first and then spend some considerable time looking at some examples of programs that have thought through what it is to deliver trauma-informed care and provide hopefully some ideas and resources to guide practitioners in delivering it. So let's start with the exploring of trauma piece. I feel as if, defining and understanding trauma can be a bit challenging, and I feel as if many of us have been coming at it as if seeing a large elephant for the first time. If you come at it from the ground in the front, you may well see it as a trunk. If you come at it from above in the front, you may see it well as a big an eye set in a leathery context. And if you come at it from the side and the ground, you may see it as a whole series of feet and trunks and maybe even a child at risk of FAS in there underneath that trunk where it's being held. Or if you see it from the rear, you may well see a tiny tail going into rather inelegantly into some water. And in fact, when actually all these images, I should say, come from the website of a woman cellist named Jamie Sieber, who went to Thailand to play with the Thai Elephant Orchestra, a great CD if you're interested in music by elephants. In fact, when I and a bunch of other researchers from the IMPART research training group looked to the literature on trauma and its connection to gender and resiliency and substance use, we found different knowledge depending on which lens of research we came to it from. So the biomedical folks found stuff around neurobiological alterations and the HPA axis, etc. The clinical folks found lots of stuff about post-traumatic stress disorder. And of course, those of us working in health determinants and health services-oriented research found very different influences on trauma, gender, resiliency, and substance use. There's a lot of interesting work being done in all these areas. But I don't have the time or expertise to speak from all of them today, and I'm going to focus mostly on the health services and health determinants area, and hope you will enjoy seeing it from that lens and seeing just how connected that is to our work on prevention of fetal alcohol syndrome. So the next three slides provide definitions of trauma, which a group of 6 researchers and I recently discussed for an hour on a webcast that you can find on one of my various websites. And it took us quite a bit of time to think through some of the differences and some of the subtleties of the definitions of trauma, which I won't go through here, but you will be able to see some commonalities and differences amongst them. The first one's a definition used for a large study done in the US, Women Co-occurring Disorders and Violence Study, that I'm going to mention a number of times today. But it defines trauma as experiencing, witnessing, or being threatened with an event or events that involve injury, a threat to integrity of oneself or others, and even possible death. And the important thing, I think, is that the responses to these events, that we experience of fear and helplessness and or horror. Stephanie Covington, and I'm going to talk a little bit more about her work later on in this work around working with trauma, and one of the models of trauma-informed care talks about how violence, trauma, abuse, and post-traumatic stress disorder are often used interchangeably, and that she thinks the clarification of that is to think of trauma as a response to violence or some overwhelmingly negative experience. It's both an event and a response to the event. And again, she sees the response as being one of overwhelming fear, helplessness, or horror. And that PTSD is really only one type of the disorder that results from trauma. And for women, often depression can be one of the most common responses and not necessarily post-traumatic stress disorder. And here's another more social determinants of health definition from Berman and Mason from Women's College Hospital in Toronto. And they focus sort of on the disruption in relationships and the disconnection that can happen from a whole range of sources of trauma, whether that be political oppression or forced uprooting or dislocation from a family, community, heritage, or culture. So they widen it out a fair bit. But in the work with women that we've been doing in British Columbia and across the country, we've often used very simple ways of describing trauma as have been defined in this small pamphlet from the Centre for Addiction and Mental Health in Ontario. An emotional response when an injury overwhelms us. The injury could be physical, sexual, or emotional, and some of the most common traumatic events in the lives of women and men include physical assault or sexual assault or verbal assault or being threatened or witnessing violence against others or long-term neglect in childhood. And I like this pamphlet because it goes on to talk a little bit in plain language about how trauma can affect people. It can affect the way you feel, and you might experience some or all of the following symptoms: too much emotion, or too little or no emotion, or depression, or hopelessness, helplessness, worthlessness, shame, fear, anger, rage, grief, sadness, anxiety, panic attacks, etc. So it kind of helps people see themselves and maybe their individual response related to trauma. Can also really, it goes on to talk lots about the relational impacts of trauma and not knowing how to trust or finding it difficult to be close to people, having problems in sexual relationships, being afraid of others, being isolated and withdrawn, not recognizing when you're in a dangerous situation, not knowing how to give and take in relationships, repeatedly searching for someone to rescue you, etc. So it becomes a place of kind of talking about how what your reaction to trauma might have been. And then it talks also about the physical aspects of trauma, that you might experience body memories and flashbacks, including seeing images, hearing voices or sounds, or smelling odors, as well as unexplained tastes and physical sensations in your body. And sleep problems, and a whole range of physical complaints and physical exhaustion. So it's kind of a nice way of kind of normalizing, pointing out the whole range of different ways in which trauma can be experienced. And finally, in this pamphlet, they also talk about how trauma can affect kind of the way you think or your addictive responses in some ways. It can lead to self-injury, addictions of various kinds, constantly looking for sexual relationships, and being abusive towards others. So suffice to say, that the effects of violence and abuse are often enduring and profound. They can shape every aspect of a woman's life, even years after the traumatic experience has occurred, and are particularly traumatic when the violence is ongoing, begins in childhood, and it's perpetrated by someone the woman loves and should be able to trust. So the long-term effects can lead women to develop coping strategies to manage the effects of overwhelming traumatic stress. And survivors of severe and chronic child abuse and neglect may present with a kind of a bewildering array of symptoms, or what Laurie Haskell, Dr. Haskell talks as adaptations. They have significantly more insomnia, sexual dysfunction, dissociation, anger, suicidality, self-harm, drug and alcohol addiction, and then a whole range of other issues, more so than other clients. And that these defenses that many women develop after being repeatedly hurt in relationships can make connecting with them very difficult. So these are women who come to our services who may be particularly challenging and whom we may have seen as difficult, hard to reach, very much the challenging client. And hopefully in the course of this session we'll start to move towards a shift in that paradigm to seeing these women differently. Long-term effects, again, just a summary from Dr. Haskell from her amazing book, First Stage Trauma Treatment, can include feelings of powerlessness, dissociation, difficulty with relationships, somatization, and I'm going to talk more about that in a minute here, self-blame and poor self-image, and vulnerability to further abuse. So the somatization part can look quite like this, connected to central nervous system changes, sleep disorders, cardiovascular problems, gastrointestinal and genitourinary problems, reproductive and sexual health problems. And that sense of chronic danger and anticipation of violence can stress the immune system, and which can lead to a increased susceptibility to autoimmune disorders such as chronic fatigue and fibromyalgia and other illnesses. And substance abuse can also be linked to all of these above problems. And in addition to related physical health problems such as liver problems and lung disease. So we often see women in our services presenting with physical health problems that we may well not be associating with the experience of trauma. And therefore, by not providing trauma-informed care, don't help them get to the root of these issues. Now, the connection with substance use is pretty direct and clear in lots of ways. Women with experiences of trauma may have difficulty managing their experiences and emotions. This can lead to the use of alcohol and other drugs. They can experience the short-term positive effects that drugs and alcohol can provide, and can increase their time using the drug, decrease their time using other skills. The skills erode, and the circle goes around and around again and again. And so, you know, as the women in this workshop in 1994 that I was at said, that women's substance misuse is a way of coping, which initially facilitates coping, while over time may take away their power choices. I would add now health and abilities. And this is another connection to substance use where you can see the direct connection between the experience of violence that may be overwhelming, in this case girls who'd experienced dating violence, and their likelihood of smoking heavily, binge drinking, using cocaine, diet pills, being pregnant, considering suicide, etc. The odds of those things being very much increased by that experience of violence. And these are connections that we may not get if she comes to a service that is looking specifically at the issue of violence. So really what we've been starting to do, I feel, is to really make these links at how trauma can be so connected to substance use problems, mental ill health, increased vulnerability to violence against women, and also influence to the positive or the negative by these related determinants of health that are sitting outside these circles, which can pile up in some ways to be particularly destructive to women's health, such as experiences of poverty or incarceration or isolation, loss of custody, racism, and exposure to further violence. So lots of links to be made from the part of us as service providers, researchers, and policymakers. And in fact, you know, that's what the literature will tell us if you go into the literature on the connections, is that as many as 2/3 of women with substance use problems report concurrent mental health problems, and they also commonly report surviving physical and sexual abuse. So lots of literature on this at this point. Dr. Katrina Brown did a study in 6 Canadian women's treatment centers not too long ago, I think it was in 2008 and 2009, and found that 90% of the women interviewed reported childhood or adult abuse histories in relation to their use of problematic use of alcohol. And 93% of women overall reported childhood or adult abuse and other forms of trauma. And, you know, it wouldn't be right not to mention the incredible extent of violence against Aboriginal women. This is from the Native Women's Association of Canada site, and they're linked to Amnesty International site, just showing how much more likely Aboriginal women in Canada are to experience violence and also to die from violence. So that's kind of a statement of trauma and its connections, and I just wanted to pull it into our knowledge of FASD and prevention of FASD. And this is a famous study that many of you may already be aware of if you've been coming to the FASD Learning Series ones, which is a study of birth mothers done in Washington State, where they attempted to track the birth mothers of the children who'd been diagnosed as having fetal alcohol syndrome in the Washington State diagnostic clinics. And of the women, they were able to they couldn't find 40 of the mothers of the 160 because of confidentiality issues related to child protection, etc. 40 of the mothers were dead or presumed dead, an astonishingly high mortality rate. And you can see that the experience of trauma and violence and mental illness and isolation and challenges for these mothers were extraordinarily high. And that's why I've been so pleased to have the chance to make this speech in the context of this learning series, because I think it's an important missing piece that we as people thinking about prevention of FAS haven't really fully integrated into our work. So now I want to talk a little bit about how we have responded as services, and then move into how we might respond. So here's where we've been. You recognize this picture? The services about substance use problems, the services about violence, and the services about mental illness and mental health have been separate, compartmentalized, have a lot of misinformation across them, and a lot of territoriality. We have not been delivering integrated care. And if women went to the substance use service and had an experience of current violence, they might well be turned away and told to go to a violence service and deal with that problem first. If they went to a mental health service and they had a serious substance use problem, they might well be told to go and deal with their substance use problem and come back when they're ready to actually deal with their depression, etc. We've just had an amazing, what the British folks have called a mystifying separation amongst these services, that serving with women who clearly have these interconnected issues. And not only have these services been separated in the way we've dealt with women, but we've in many ways kind of perpetuated or reproduced those dynamics of power already experienced in a woman's relationship, and have perpetuated a sense of powerlessness in the context of our work with women. Many service providers, this is from the BC Building Bridges research, many service providers do not recognize or understand the multiple varied and complex effects of abuse-related trauma. Many traumatized women seeking help are not only misunderstood and not given the help they need, but are also re-traumatized. And this often results in them refusing care or not trying again to get the help that they so richly deserve. So in some ways I feel like, you know, we need to do this shift that has been talked about in the UK as well in this report called Gender Informed Practice, is this shift from seeing what's wrong with her and seeing her as a problem client to thinking about what has happened to her and therefore what our response needs to be. So we need to change our language from seeing these women as controlling or paranoid or manipulative or uncooperative, untreatable, attention-seeking, drug-seeking, bad mothers, not believable. You know, we could go on and on and on, right, with these ways in which we've seen the women with these multiple experiences of substance use issues, mental health concerns, and experience of trauma as they've appeared at our services. We've often, again, in this Building Bridges research from British Columbia, the services often have a single issue focus. They don't have a gender focus. There's a lack of awareness of how an abusive partner can actually interfere with access, such as you saw in the FASD research study from Washington State, and how we can be creating more pressure on women to come to our services when in fact they're experiencing the pressure from their partner to not come. The lack of awareness of how a mental health diagnosis can interfere with access to services, and a lack of awareness of how substance use treatment may be ineffective without addressing women abuse. So lots of challenges in the way we've done it. And then back to the study by Katrina Brown from Halifax who has talked a lot about how women then internalize these stories about gender relationships and violence and end up kind of minimizing it themselves, blaming themselves, and being very ambivalent about trauma in their lives. And their internalized stories about addiction as well, about how abstinence is the only direction to go, and how you know, that you're an addict and will never be able to use substances again, that you're bad for using substances, etc. Means that they often don't contextualize their drinking and see it as something they did as a positive coping strategy to manage the symptoms of trauma that, you know, has become less of a positive coping and now needs to, other strategies need to be found. So the trauma issues are often poorly addressed and has lots of serious ramifications for the outcome of women's treatment. Coming back to that idea of the circles and the determinants of health that become impinging on women's experience of the three: violence, mental health, and addictions as well, that it becomes this compounded issue as well, because the women who have been impacted by violence and trauma are at greater risk of barriers to housing, are at greater risk of losing contact with their children, are more often to be poor, and this becomes a barrier to accessing particularly substance use treatment services, become even more isolated, etc. So we keep having this compounding, no way out trajectory. And here's one of the women from the Halifax, the study by Katrina Brown from Dalhousie in Halifax, that the women then end up saying to us, you know, I think you need to deal with these issues. If you don't deal with these issues, there's one thing to take away: the alcohol, and not deal with nothing. You've taken that away, but you're still just as miserable as you were when you were drinking, so you may as well be drinking. So that sense of discouragement and powerlessness comes into play when we have addictions treatment centers that are just focused on getting rid of the alcohol and not thinking about the co-occurring issues. And of course, again, I feel like I always need to come back to how significant this is for Aboriginal people in Canada. And to honor Deborah Chansonov's point here from the residential school trauma writing that she's done, that healing in a larger cultural context therefore requires a commitment to fostering social, political, and economic conditions of re-empowerment. So there's kind of a politics of healing from the perspective of Aboriginal people as well. So that's where we've been in some ways, both our emerging understanding of what trauma is and the challenges in the way we have responded to date. And now I want to move to where we might be going, or where I'm definitely trying to help us go in lots of ways. And so I'm a researcher interested in health service systems and their response to women's health issues. So I'm really interested in this idea of trauma-informed systems and services. And by that I mean, and I'm quoting here Maxine Harris and Roger Fallot from the US, who've written an amazing book way back in 2001 now, called Using Trauma Theory to Design Service Systems. And they talk about trauma-informed systems and services as ones that understand the role that violence and trauma play in the lives of most people who access substance use and mental health services, and integrate this knowledge in all aspects of service delivery, including supporting survivors to manage their symptoms successfully, and so that they're able to access, retain, and benefit from the services. And it means not only do services and systems accommodate the vulnerabilities of trauma survivors, but they actually facilitate survivors' participation in treatment. So that sense that we've been building up of isolation, overwhelm, inability to access gets completely turned on its head to be the sole point of our work. They go on to talk a little bit about trauma-informed counseling specifically in terms of understanding the connections and understanding the way that people may be presenting as attempts to cope as opposed to problematic symptoms, right? And they also really stress this piece, which I think is a really important one, that you don't have to disclose a trauma history to receive these trauma-sensitive services, that all services will be sensitive to that. And I think we've often focused on this idea that, we need to get people into services and we need to immediately be screening for trauma issues. And what they're saying is, au contraire, that we start from the recognition that a lot of women coming to services for mental health and substance use concerns will have trauma histories, and they don't have to disclose that history of trauma before they receive trauma-sensitive services. And the way we do that is by staff being knowledgeable about the impact and to behave in ways that are not re-traumatizing. And that behind that trauma-informed support, there will be trauma-specific services. And so here I've just laid out a little bit about the difference between what I mean by trauma-informed and trauma-specific. That trauma-informed take into account the impact of trauma and integrate this in the knowledge within the way they deliver services. And trauma-specific services do that and directly address the impact of trauma and facilitate healing. So a more specific approach to healing beyond simply being informed and being concerned about access and support and not re-traumatizing. So I want to talk now about trauma-informed work at various levels in our system of care, starting with brief conversations and moving up to more specific trauma services. So I just wanted to turn back to this slide, which I think I've used before in presentations to this group, this reinforcement from the scientists about intervention not being a specialist issue, not just being done by substance use counselors, but that all of us need to, wherever location we are, to be able to talk about substance use problems. And we have the social responsibility, and I think ethical responsibility, to do so. So way back in 2002, Wendy Reynolds from the AWARE group in Kingston, and Margaret Leslie from the Breaking the Cycle group in Toronto wrote this great manual called the SMART Guide. And they mentioned in that some ways of asking questions to women who may be at risk of having a child with FASD, and they used it in this very plain language way that I think has some really strong elements of trauma-informed care in it, about being non-judgmental and really working to understand the benefits of substance use for her and help her see what the positive intent was behind there, and to consider other ways, other small steps towards change that she might be able to achieve. And in fact, in the substance use field, one of our key evidence-based forms of support in the field is motivational interviewing, which again really stresses a trauma-informed, or is very consistent with the trauma-informed approach, especially in this aspect of the spirit of it that's about collaboration and avoiding confrontation and focusing on a partner-like relationship with the client as opposed to a power over type. And in fact, that relational connection, the idea of hope, and the factors that people bring to counseling, like experiences of trauma, are indeed the keys that have been found by the American Psychological Association researchers here around what really matters in terms of what works in therapy. Our relationship, our generating of hope, and our willingness to really think about what the person is bringing to the counseling situation, create the most, contribute the most to what works in therapy as opposed to any particular technique that we might bring. So that extra therapeutic factor is really a lot about what's happened to her as opposed to what's wrong with her. So let's talk a little bit about the trauma-specific services, a little more intense than actually thinking through the conversations that we might be having. Laurie Haskell, Dr. Haskell again, in this first stage trauma treatment booklet, talks lots about these essential components of first stage trauma treatment: establishing a therapeutic alliance, promoting client safety, addressing clients' immediate needs, as opposed to perhaps our thinking about what we're delivering, normalizing and validating the client's experiences, and educating the client about post-traumatic stress and treatment, very much like that pamphlet that I started off this presentation with. She goes on to talk a little bit about using a gender-sensitive approach, nurturing hope, emphasizing strengths, collaboratively generating treatment goals, teaching coping skills, and managing and helping women manage these adaptations or symptoms of their post-traumatic stress responses. She talks about increasing the client's sense of control over their lives by familiarizing them with post-traumatic stress responses and the reasons for these adaptations, helping with coping skills, helping women distinguish between the situations over which they have control and those larger inequities, and to understand how their lives are shaped by the context in which they live. And increasing client sense of safety in all contexts. So safety, I think, is the core concept that she's been really helping us understand as central. And in that, I think, is really helping clients identify their own responses to trauma from those, from that pamphlet, and to reframe them in a less blaming way. So instead of seeing themselves as wrong or inadequate or a bad mother or any of those other kinds of labels that we saw before, but to see them as genuine responses to trying to maintain their integrity in the context of that sense of overwhelming fear and horror. And really see how presently that's acting in their and working in their lives or not working for them, and really start to begin to help them form meaningful connections with other people. So instead of seeing these people as these women as difficult to treat or hard to make a connection with, we just make that the focus of our work. It's really saying, you know, connect this sense of disconnection and overwhelm that you've been experiencing is really, you know, the place we need to begin, and to work with you on building trust and learning that trust is possible. I want to talk about a few models for this trauma-specific work that were used in the context of this large study in the US that was the first large-scale multi-site effort to develop and evaluate integrated mental health, substance, and violence use services. And just want to mention that in this study, the involvement of consumers and survivors of trauma were integral to the process, and I think is really coming back to that idea that this is about engagement and connection and bringing them in rather than designing service systems and then expecting them to fit into the services. These are some of the models that they used in case people are interested in looking them up. I'm going to talk a little bit about seeking safety and TREM here this morning, but there are lots of other models as well. Seeking safety model may be one that you're well familiar with if you are at all interested in integrated work on trauma and substance use issues, designed by Dr. Lisa Nashevitz in the US. And it's a very present-focused and structured approach to supporting women and men, and it's been used in a lot of contexts, and it's really designed to promote safety and recovery. So based on, again, on that idea of safety, on the idea of interpersonal connection, on hope, on showing compassion, giving women back control, really spending lots of time helping them have a voice and building alliance. So the sessions are very much about, you know, coming together and talking about a quote that maybe that has come from the literature that people can see their relationship to, talking about specific skills for building strengths and coping connections, and also about moving forth with making a commitment to do something positive for themselves and to build a connection over the week. The Victoria Women's Sexual Assault Centre saw the need for offering a seeking safety group in Victoria, and they linked with the Vancouver Island Health Authority, who deliver addiction services, and they have run an outpatient group now for a couple of times a year by a trauma counsellor and an addiction counsellor. They adapted the seeking safety model to do a piece about seeking information initially, where they have 3 weeks where people can come, women can come, and simply focus on coping strategies. You don't have to commit to the whole group, you don't have to come every time, etc. But just gives you a chance to kind of try out the work around learning coping strategies. And then you can commit to a seeking understanding group, which is 12 weeks, that examines more specifically trauma topics related to trauma and substance use in more depth. The evaluation findings, I did the evaluation of an early set of these groups for the Victoria Women's Sexual Assault Centre, and here's what the women said, that they found it created safety to explore both issues. It really gave them lots of learning about the effects of trauma and skills to manage their adaptations to it. There was real reduction in the stigma they felt about it, and more self-acceptance. They felt that it really helped them break through isolation and connect with other women and develop hope for the future. A couple of other models for working in an integrated way on trauma recovery and empowerment is one by Maxine Harris from Washington, D.C. And this particular model just works with group discussions that have 3 parts: empowerment, strategies for self-comfort, and accurate self-monitoring. A section around reframing connections and understanding the connections amongst these issues within their lives. And again, lots of skill building on decision making, regulating affect, overwhelming feelings, establishing safer relationships. So you can see lots of common threads amongst these models, and see where we could come in on that. I brought with me today this one of the, it's a very murky picture there, I'm sorry, the Beyond Trauma from Dr. Stephanie Covington. She's done lots of work in Canada in helping design programs within the prisons in Canada for women with multiple issues of trauma, mental health, and substance use issues. And this particular strengths-based, gender-responsive, trauma-specific group curriculum also gives lots of great ideas for helping women make connections, see the impact of trauma on their lives, and heal through grounding and self-soothing, making mind-body connections, exploring feelings, exploring relationships, and also spirituality. So the conclusions from these models, like Seeking Safety and TREM, et cetera, that were used in the context of the Women Co-occurring Disorders and Violence study, was that women in this integrated care, where these things were worked on or acknowledged together, experienced significantly more reductions in symptoms of mental illness, alcohol, and drug use compared to women in traditional services, and the service costs are no higher. They talked lots again about, you know, the great benefits of it. You can see it in your handouts of being, you know, what the women were able to achieve in managing symptoms, understanding the way trauma works in their lives, having more agency and quality of life and self-esteem, and more capacity for mutuality in relationships, skills. And I think what was really interesting in the Women Co-occurring Disorders and Violence study, that the service providers, the consumers, and the health system planners work together all the way through the process of this service redesign and study. And in the end, really tried to make treatment become a web of relationships rather than another experience of power over. So, we can be trauma-informed in lots of different ways, and one of the ways I just wanted to quickly share with you was the work of the Jean Tweed Center in Toronto, who decided as an addiction service that they needed to think about the trauma-informed way of working. And they did notice the extent of trauma within their service. They began by reading together and getting funding for a trauma counselor. They started to really proactively work on this in their programming, including asking women about trauma, etc. And in the first round of evaluation, noticed that in some cases they were creating instability and not actually helping women stabilize in the connection. So they shifted to a trauma-informed approach in which they became more aware of the issues, but they weren't as proactive in forcing women to talk about the trauma. They created the space and the safety for women to raise it as it felt more safe and ready for them. And they asked themselves about how they could continue to develop their depth and capacity in working, and began to do some training in mindfulness and to offer the option for mindfulness as a way of managing symptoms for the clients and for themselves, to see about how it can bring a sense of peace and locus of control and affect regulation. So they did it themselves as staff and offered it for the clients. And they began to do the training with the Seeking Safety model and reworked the program's approach to relapse prevention, reworked the program overall to address how it's helpful to name the trauma and to create a safe place where women can talk about their experience and to offer this kind of skills for coping. And now all of their programs are trauma-informed. They do still have the trauma counselor, but she does individual counseling for women post-treatment. She also supports the staff for the women that are living in residence. She works with them on doing a Seeking Safety group that women can voluntarily go to, and for at whatever stage they're in at the center. And they now, in addition, have outreach programs to pregnant and parenting women who, again, can, where this trauma-informed support is braided in. And the children of the mothers accessing their mothers and children programming, who are also affected by trauma, are engaged with attachment exercises and play therapy as well. So I wanted to just share that work around them, what they call braiding in trauma, response to trauma within the context of an addiction service, to become a trauma-informed service, not necessarily to treat trauma at all levels, but to look to women to signal their readiness to work on it, not imposing it, thinking about their education needs, supporting pacing, putting in place good clinical supervision, doing lots of peer support for staff and clients, and of course always keeping evaluation at the core. Coming back again to our work with Aboriginal people on trauma-informed work, it can be very different in the context of Aboriginal healing, especially with the ongoing impacts of intergenerational trauma and ongoing colonization. And I wanted to mention this great study done by Colleen Dell and from the University of Saskatchewan, and a group of Aboriginal women. She engaged in a community-based research project within the NADAP treatment centers in various locations. And they came up with their idea of what they would like from a treatment provider in the context of the NADAP treatment programs. And I think it's very interesting. I don't know whether any of you have seen the DVD clip that comes from this study. It's called From Stilettos to Moccasins. It's an amazing, empowering little clip showing this concept of reclaim and this concepts that they were looking for as pieces of their healing process of being shown empathy, acceptance, inspiration, a recognition of the impact of trauma in women's healing. Communication, care, the link to spirituality, and this sense of momentum, assisting women to move forward towards the future, and acknowledging the past as well, and assisting women in developing healthier relationships and parenting skills, fostering women's ties to communities, etc. So I feel like what they found in the context of this particular study was exactly an example of trauma-informed care in terms of their ideas about what they wish the service providers would be able to convey. The From Stilettos to Moccasins clip is on YouTube. You can just type in those words, stilettos to moccasins, and get it. So we've talked a bit about trauma-informed care in terms of brief conversations by a range of service providers. We've talked about trauma-informed care in the context of more significant interventions, bringing it into a women's treatment context. I just wanted to talk a little bit about trauma-informed care on the community level and mention that there are a number of community-based peer support groups, etc., that are beginning to acknowledge how trauma is related to peer support on and mutual aid on substance use issues. I just wanted to mention this one program, again an American one, but there are a lot of examples of this program operating in Canada, called the 16 Steps for Discovery and Empowerment. It's a model based on love, internal control, affirmation, trust in the ability to find their own healing path. That sense of hope is another word that keeps popping up in all these trauma-informed models. And it's based on this idea of healing from addictions as really about validating the underlying positive survival goals for safety, connection, love, and power. And so instead of making women wrong for having used substances and gotten in trouble with substances as they manage their traumas, their experiences of trauma, it's really focused on acknowledging that it was a positive intent behind the use and helping them find other more positive ways to meet those needs. It's a great book around, from Charlotte Castle, around how to organize and support those groups, called Yes You Can, Healing from Trauma and Addiction with Love, Strength, and Power. And I wanted to mention this BC study we did a few years ago on women's use of substances as they came into transition houses in BC and 3 months later. And one of the things we found was that when women came into transition houses, that whether or not the house provided a specific intervention on alcohol and other substance use, the women's use significantly declined after having been in a transition house. And when we talked to the women, some of the things that they said was, you know, I had the experience of being pulled out of a violent situation. I had the experience of getting enough sleep and food and connections to other women, the chance to find myself a new apartment, get connected to a job, etc. And so even those basic life needs for safety, connection, and health made a significant difference in their substance use. And it was just a reminder to us that, you know, problematic substance use isn't always about addiction. It's about managing difficult situations. And if the difficult situations are removed, there's lots of positive change that's possible. So that's sort of the flip side of trauma-informed, is sort of substance-informed approach within the context of those services. They didn't necessarily intervene on the substance use, but they made a huge difference by doing that, except for the smoking. The tobacco smoking did not decrease. And that's another whole story we're doing a fair bit of research and thinking about at the Center of Excellence for Women's Health, is trauma-informed tobacco treatment as well. But that's another day and another story. Wanted to talk a little bit about the system level work, because I feel like so often the trauma-informed practice is needs to be built into a system of care, and that in some ways it's about us on the system level finding ways to connect work well together in the same way as we're inviting the women to think about the reconnections that they need to make in their lives. And so often when I've been speaking to service providers and health system planners about this work, it's often seen as something that isn't possible unless the multiple levels of committed service providers, committed health system planners, and lots of staff education and clinical supervision is available, and lots of involvement by the women involved in with the problem, in helping all of us design services that really do work well. So I think so often we keep the lens on this level of work, which is how do we offer good groups and good programs, and we don't think well enough about how do we embed it in our systems so that the counselors on the front line who may have the commitment to offer this kind of intervention really get our support and direction in the context of it. Because otherwise, it's just a lot of hard work of seeing women day by day who have experience of trauma and having our own sense of vicarious trauma just keeping piling up without feeling like we have a system that's there to support this work. The Women Co-occurring Disorders and Violence study in the US found that there were lots of challenges in building it in on a system level. And they talked about the incredible importance of establishing and maintaining buy-in from the mental health system, from the addiction system, from the violence system, from the pregnancy outreach programs, from the parenting programs, from anywhere that a woman, or in our case around FAS prevention, a pregnant woman specifically, may turn up in the system. So we need to get buy-in for working in a trauma-informed way across these different kinds of services, and we need to really think about how do we build these relationships. Lots of ways. We've started to do it in the pregnancy area with perinatal service networks, but they often are simply about the maternity care level of things and not necessarily widening to the mental health and substance use field more widely. And so that compartmentalization still sits where, people working in detox may not be that comfortable working with a pregnant woman, and people working with a pregnant woman may not be that comfortable with the addictions issues. And we continue then to not have the kind of support that we'd like for women at risk of having a child with FASD. They say that it's so much about relationship building. It's so much about inclusion of a broad range of stakeholders, and it certainly involves some strong leadership and commitment to make this service system integration. They stressed as well in this study that the consumer, survivor, recovering woman, the CSRs as they called them, their participation was critical. And that part of their participation that they worked on was developing and supporting the empowerment of women who've been there to be able to participate in planning and training. And they developed a kind of a curriculum of that they actually gave an accreditation to, which was a Leadership Institute kind of curriculum for the women themselves, so that they could meaningfully participate in joint planning with health system planners and service providers. But they felt that critical to the success of the kinds of programs they offered and the way they embedded them in service systems across the states, it was very strongly, it was in Florida, California, Massachusetts, New York, a number of the larger states in the US where they did the pilots in this study. And it was really critical, they felt, to keep to that idea that in Canada we've used the term "nothing about us without us" in the harm reduction movement, and in this case that was very clearly woven in and critical to their success. And interestingly, was also seen in the models such as the Jean Tweed one and the Victoria Women's Sexual Assault Centre, where the women themselves were very much part of guiding how the service would be delivered, and ended up offering better ideas for how to deliver. Even the Seeking Safety group at the Victoria Women's Sexual Assault Centre, that idea of breaking the first 3 sessions off to be ones that have no commitment, long-term commitment to them. Just come, learn coping skills. If you don't want to carry on to the 12-week group, fine. And there were a number of women who, in that evaluation, who said, thank you. I got more in these 3 sessions with you than I've gotten in the many years of counseling I've had in other locations. And that's all I needed. Thank you. And left the service system empowered by that kind of short-term, not long-term commitment support. On the other hand, in the Women Co-occurring Disorders and Violence study, they also found a fair bit of resistance to this paradigm shift, to becoming trauma-informed. And they felt that that took a lot of ongoing work to continue to help people see their own field as not the be-all and end-all, but to really move to a paradigm where the integration is what's important, and the connection with women is what's important, and the shift to seeing the women as and their empowerment and their need for reparation in relationships as the central issue, as so critical. And that meant that there did need to be lots of cross-training, and there needed to be lots of attention brought to supervision and support of the workers. So you can see that I definitely am a health system planner kind of researcher, because this is the part that I feel that we often skip over. We stay in the clinical area, and we don't necessarily stay in this part where that is so critical to our understanding around shifting the focus to being about how we organize ourselves in order that we can deliver trauma-informed care. So I wanted to wrap up today and give some chance for people to talk and think a bit about it by talking a little bit about some of the resources that are available to us in an ongoing way to keep this dialogue open. And I started off today talking about that pamphlet from the Center for Addiction and Mental Health. It so clearly, in plain language, described what trauma is and some of the effects that people might feel from trauma. There are a range of incredibly useful resources, that one and many others, on the website of the Center for Addiction and Mental Health. But that one I feel is particularly, that simple little pamphlet is particularly helpful in us opening the conversation with women, giving them information in a way that doesn't say, have you experienced trauma, but you know, have a look at this and see how this sits for you. So that it's not about screening as much as it is about opening the discussion and teaching about how some of the things that they may see as negatives in themselves are actually very positive ways of coping, and things that may be experienced, may be related to their experience of trauma. The health center in Winnipeg have created this little trauma toolkit. They're called Clinic, and you can download it if you type in the Clinic with a K and trauma-informed toolkit. It is a resource for service organizations and providers to deliver services that are trauma-informed. There's a number of great things in here. and one of the things that they have near the end of this is a bit more depth than I've been able to provide today around what trauma-informed practice looks like, laid out within this context of a trauma toolkit. On my website, the Coalescing on Women and Substance Use Issues, there's a whole range of resources on working in a trauma-informed way, and a whole range of links to webcasts where we have been wrestling with this idea of trauma-informed work over the last few years. And most of the pieces on that website are about are sort of guidebooks and questions that have arisen out of getting involved in virtual communities of practice, where we discuss what it means to be trauma-informed, what it means to provide good substance use care for women, and that's integrated with trauma and mental health services, etc. And lots of possibility for to getting connected to the virtual communities that are ongoing at the Centre of Excellence. Also at BC Women's Hospital, where the Centre of Excellence is the research that I referred to quite a lot today around the Building Bridges research. Again, you can just type in BC Women's Hospital and woman abuse, and you'll find, or Building Bridges, and you'll find it. It's kind of a long link there, but I thought I'd put the whole thing for those of you who have the handout. There's also some very interesting research being done by a group at McMaster's University called Connections. They're working on knowledge exchange issues there, where they've looked at the evidence for the integration of programs that are trauma-informed, support mothering, as well as mental health and substance use issues. These researchers at McMaster have done an amazing job of meta-analysis and meta-synthesis of all the literature available to us on the importance of integrated care on mothering, violence, mental health, and substance use issues. And they're about to engage in a large national knowledge exchange process where they share and work with organizations across Canada who are interested in shifting their practice based on that research. So another possibility for getting connected and thinking through where we might go from here. Finally, I wanted to mention CAST Canada, which is not a women-specific service or group, but is a group organized by a guy named Tom Regier, who's a survivor himself of trauma issues and is doing an amazing job of building a consumer empowerment group around trauma-informed work and trauma-specific work in Canada. There's a lot of other great sites and information available, and I wanted to just mention this idea about screening and disclosure, because I've been, circling around it in this presentation a bit about thinking through how we do talk about trauma and violence with women. And this work that's been done in Ontario, the Ontario Woman Abuse Screening Project, has some quite significant work on their site, which explores these issues in some depth about how do we screen and create safety in the context of that work. So if that's a particular interest area for you, I really encourage you to engage with that material. On the Coalescing site that I mentioned previously, there's a webcast where Dr. Vivian Brown from that Women and Co-occurring Disorders and Violence study from the US talks about a screening tool that they built in on the system-wide level to help identify people with all three issues. So it's a 9-question screening tool. that has 3 questions about substance use, 3 questions about mental health issues, and 3 questions about violence and experience of trauma. That they've built in on a kind of a statewide area as a way of, instead of forcing disclosure, as a way of helping people acknowledge the interconnections amongst the issues. And they preface their screening process by saying, you don't have to answer any of these questions. But we are going to ask these 9 questions about these 3 issues because we find they often go together. And we find it's often helpful for people to think through, you know, what kinds of support they might want that's connected to these issues. So instead of becoming another sort of place of lack of safety where women might not feel safe to tell, it becomes a place of saying, we're asking this because we see this integration. So it's almost more like a point of trauma-informed screening and education rather than a thing that's going to be written on your file as something that may put you at risk of losing custody. So lots of issues on that. And some other great Canadian work is on the connection between trauma-informed work and working with people who are homeless. And as you can, you know, imagine, there's lots of homeless people with these 3 multiple issues. And just wanted to say, acknowledge the tremendous work by this National Center on Family Homelessness and their work to integrate it. So I feel like we're at this place of momentum, right? That lots of people are starting to get interested in this concept of trauma-informed care and to think through what does it mean in our system or our service area. Whoops. What did I do here? Since I've mentioned the American work so much today, I felt like I should include some USA websites as well. The work of the SAMHSA Trauma-Informed Care Center, that's the Substance Abuse Mental Health Services Administration, the key mental health and substance use government-driven agency in the U.S., has just tons of material on this site. There's all the 12 or 13 different studies related to the women co-occurring disorders and violence overall study are all listed on this site. The work of Maxine Harris in defining trauma-informed care initially is at this community connection site. The Seeking Safety Manual and lots of related great materials from that Seeking Safety model are available on Lisa Najavic's site. One of the things that's also great in terms of screening and whatever on her site is that she actually has some cards that like playing cards almost, that relate to different coping strategies that women can look to and pull ideas for and work with 2 or 3 of them at a time. So really demystifying and pathologizing, I guess, the idea of what might be better coping strategies. Stephanie Covington's site has a whole range of amazing manuals on it, including manuals directed at trauma-informed work with girls as well as with women, and some great material also on the National Trauma Consortium site. So you won't be short of places to go to from here on in. One of the virtual communities that I led around this concept of trauma-informed work developed this little handout that you can download from the Coalescing website. But it describes a little bit about trauma-informed approaches in addictions treatment, but it also provides a range of questions for people about that might be useful, and these are just 3 of them, that might be useful to take to your services or your systems of services to ask yourselves about how have you noticed the links amongst these things in the context of the women you serve? And does your service assume that violence has played some role in women's lives, even if she's not identified it? And how are you currently addressing this interconnection, et cetera? So it provides you with a whole range of discussion questions and, again, the kinds of links to places to go for more information should you need it. So those were the questions that I wanted to open up today and to give you a sense, give you a chance to talk a bit about. I know I've just thrown a huge amount of information at you in the last hour and 15 minutes and was hoping that we could have a bit of discussion and questions about this, this hopefully exciting new area of work that I think is highly related to our work on FASD. So thank you. Mm-hmm.
Have you read much about cyber abuse?
No, I haven't read a lot about that. What I've read more about is some of the sites for young girls and young women that are sort of safe spaces online to be exploring some issues together. So there's a great site called Kick Action that's organized by the Girls Action Foundation, which is, based in Montreal, but leads and seeds girls groups across the country. And they've been thinking lots about the pressures coming at girls, both from online, but also from the media in general, and trying to create spaces where girls can critically evaluate what is coming at them, whether that be cyberbullying or whether that's simply the pressures to drink, to be thin, to, all the other consumer oriented towards material things, etc. So there's some really interesting sites being organized that are starting to think through that. And actually on the 24th of March, we're having a webcast at the BC Centre of Excellence for Women's Health with girls groups from across Canada talking about that work and how it's linked to the prevention of heavy drinking amongst young girls, because that's a trend we're seeing and worrying about a bit, about that pressure to drink earlier and to drink a lot and the health impacts that has, and how we can link in a trauma-informed way, link that into the work they're doing with girls' empowerment overall. So, yeah, big area, I think, for us to be concerned about. And especially concerned in terms of how vulnerable girls who have FAS themselves may be to being online and not being able to make good judgments about what's safe. And so I think there's lots of work for us to do to try and identify the places and support them to be connecting to safer places than ones that may lead them astray, so to speak, when they're so vulnerable to being socially influenced,
I think what I've often heard, Nancy, is that a lot of people are scared to address trauma because there's always that thought that you'll re-traumatize.
Mm-hmm.
So a lot of staff leave it alone.
Yeah. I feel like a lot of people said to me that they feel like it's opening Pandora's box or something. And I feel like what we're doing then instead is forcing women to handle their own Pandora's box, just so we don't have to, imagine it. And I guess that's why I've been so keen to start talking about trauma-informed care. That doesn't necessarily mean that you're treating trauma, but just that you're creating safe spaces and and connections for women to, you know, say, yeah, that's my experience. And gee, it's been difficult, but I don't have to feel bad about having that as my experience. There are, you know, there are ways of moving forth. And I think, you know, the challenge for us in some ways too is that, to me, having a trauma-informed system in care does mean that there are some trauma-specific services that we can feel confident in, that are kind of our backup. If we're going to have those initial conversations, we need to kind of have the others that we know are there. And I think that's the service system piece, where we need to feel like we've got all these systems in place for us, and so that when we feel out of our depth in any particular service, that we feel like we have our partners in the other areas that can you know, be our guidance. And I think that's what the American study showed so clearly. And you know, it's interesting in Victoria, I keep using the Victoria Women's Sexual Assault Centre as an example because it's my hometown and I know them best, and they evaluated that group of seeking safety that they did. But they're doing two other things that I didn't mention as I was going through that I think are critical. One is that when they decided to develop that service, that seeking safety group that had the 3 open-ended sessions and the 10 or 12 more intense ones on the interconnections of trauma and substance use, they didn't make the referral into that group as only from the sexual assault center and from the addiction system where the 2 counselors came from. They actually brought the Friendship Center, the sex trade worker organization, the violence against women shelter, and a whole other bunch of women's services in to be the joint referral batch, so to speak, so that already they were thinking, you know, more broadly about where might women turn up. And then the next stage of that has been that they've done some actual what they call, I think it's called TIP training, trauma-informed practice training, where they've working with each of those kinds of agencies that see women at risk in Victoria and helping them with what is trauma-informed look like what's your piece of opening the conversation so that, you know, women could in turn decide that they might want to come to the seeking safety group, so that instead of seeing it their responsibility as only delivering the group, they saw their responsibility as engaging the whole system of care for women and educating the whole system of care for women. And so it's been a really interesting process, I think, of developing a kind of a responsive safety net that's quite interesting in the Victoria area. And we're now having an emerging group of people, including them, that are trying to build a one-stop wraparound service for pregnant women with these multiple issues called Her Way Home. So again, it's, you know, the FASD prevention field is immediately linking into that and seeing how critical that the involvement with pregnant women needs to be working from this framework if we're truly to prevent FASD amongst those women who are most at risk of having a child affected. And I feel like that's been a place of most discomfort in our thinking through the prevention of FAS, is that, you know, we've been a bit more comfortable with the front end levels of FASD prevention, the discussions and the pamphlets and whatever. But as we get into the higher risk women, our sense of security, you know, and feeling like, oh my God, I don't know whether I know what I'm doing here, really starts to rise. And I think that this is the way forth for us to get partnered in the larger systems of care with the multiple sources of expertise working together and getting rid of that compartmentalization of, I'm too scared to deal with this, so I'm going to refer you over there thing, rather than seeing that my piece of this is building a relationship which I maintain with you even as we may bring in more sources of support for you, but this is not about making you feel like you can't come here. It's all about you, please come here, and let's bring you in closer and figure out ways of easing and supporting your empowerment instead of further traumatizing, I guess, by not seeing the importance of that connection. So yeah, I totally get why people feel a bit overwhelmed by it, and I so feel it parallels the same thing that the women are feeling in terms of their overwhelm. So that we need to find ways to get past that sense of just finding this difficult and big, and instead find our way to seeing it as so possible, given our current strengths and possibility of connection.
Hi, my name is Donna Vermillion. I'm calling from Tsuut'ina First Nation in just southwest of Calgary. I just wanted to, your question on are there practices that have trauma-informed care? Working on a First Nation, we definitely have multi-generational trauma care that we have to be informed of. What I'm interested, are there supports, like right now being a new program, I think 5 years or less. I've been in my position less than a year, and the support for workers dealing with multiple traumas, even questions with our clients, legal questions where they may have grounds to seek legal advice, definitely. You know, I'm kind of at a loss, definitely overwhelmed by the issues, problems that these ladies face, and as a program coordinator, the support for myself on where do I go with this, where do I, just wondering is what the picture is like in BC.
Yeah, I think that, you know, what you've raised is probably one of the most important topics that we can turn to at this point and discuss in the next few minutes, is how do we support you as workers to do this work? And I think it's the question that we need to figure out. Yesterday I was in Toronto meeting with some people from the NADAP renewal implementation group, and we raised these questions with them as a key piece of the renewal of the National Native Alcohol and Drug Abuse treatment program that do affect the on-reserve programs in the south of 60 parts of Canada. And I feel they heard strongly and clearly that this kind of education that you're talking about, that supports you as a worker on in a First Nations community to deal with the heightened experience of trauma often experienced by First Nations people in Canada is top of their agenda. You know, to think about these connections between trauma and substance use issues, and to empower and train and support and feed information to workers working across Canada. We don't have enough of that yet, and I think that it's critical that we begin to build this kind of clinical education that goes way beyond what we're able to do today in a session on a teleconference, but is actually ongoing communities of practice, communities of supervision, ongoing chance to share resources and information about how do you answer those questions about the legal issues. And I know that that there are many programs that are starting to build the kinds of answers that you have, including that one group that I mentioned a couple of times today at BC Women's, the Women Abuse Response Program, have been concerned about those kinds of issues over the past few years, as well as the links amongst the issues. So I don't have any perfect answer for you around that right now. I feel like we're all just beginning to get going on this issue, and how do we give people the kinds of resources that they need. I certainly am going to continue to work and provide more and more information of the kinds of things you're looking for on the Coalescing on Women's Substance Use site that I have up here on the slide. So I hear you and think it's incredibly important.
When you were talking about the 3 screening questions with
Yep.
violence,
Yep.
is that, can you just clarify where that's from? Or
Yeah, that is from the state of California. And it was developed by a researcher by the name of Dr. Vivian Brown. And if you connect with me, I can direct you to the actual tool itself. It's on the Coalescing in Women's Substance Use site. It's, I think it's an interesting one. And I'm just editing a book on trauma-informed care for the Center for Addiction and Mental Health, and Vivian has a chapter in the book that talks about that. It should be out not too long from now, but I just thought it was, I mentioned it today just because it's on this coalescing-virtualcommunity.org site. And I think as important as the questions are is the way that that 9-question screening tool is situated as something like we're asking these questions because we know these things are connected, and that sometimes people don't get asked them all together so that we miss things. And please know that if you're not comfortable with answering any of them, that's totally fine, and it won't affect your care, right? And so that you can just see the difference, that kind of framing of something rather than starting into a series of questions. Has your partner ever kicked you? Has your partner ever, you know, some of the conflict screening tools are really, you know, can be quite triggering in some ways and not very supportive in the way that they're situated. And I think we have lots to do to think about that. I did a study at a mental hospital in BC called Riverview a few years ago. And so a major psychiatric hospital in Vancouver area, the Lower Mainland area. And we did a kind of pilot of the idea of asking people who were entering the mental hospital about how they like to be handled when they get upset. It was just a 1-question thing really, and it was, do you prefer to go to a room quietly by yourself, right, and not have a lot of stimulation, right, when you're feeling upset? Or do you prefer to be out sort of in the community with others and not isolated in a room by yourself? You can see, right, that we were trying to do a number of things with that question. We were trying to signal that we wanted to hear their preferences for care, so putting some control back in their hands, that we were trauma-informed in the sense that we recognize that some people may have been locked in a room alone or whatever in a traumatizing way in their past, right? And that if that was the way the hospital reacted to them when they were feeling upset, that was actually going to be re-traumatizing, right? And might then in turn lead to this, you know, kind of a restraints context and going down a whole other road. And it was very interesting very challenging to shift the practice around that. But when I interviewed the patients later on down the road, they said, what an amazing experience that was to be asked, even as you're getting admitted, you know, when you already may be upset, to be asked a question like that, that signaled that the provider was actually listening to your preferences for care. That one simple thing shifted their whole experience of what it was going to be admitted, right? And so I think, you know, I think it's just such an example of how non-complicated and how powerful the single question could be in the context of anybody's service, of just thinking through, you know, how are we reacting to people as they come in the door. And often in this literature on trauma and trauma-informed care, there's a lot of attention paid to that first interview or first experience of coming to a service. And what do we do in that moment? Right? You can have the best counselors in the world down in their offices, but if that first moment of coming to the service doesn't feel safe at the front desk, or in the way you're asked questions, or the amount of information you're forced to give before you're even talked to, can make the huge difference between whether you come back or whether you stay or whether you get the kind of care that you need. And if we're thinking about young women with FAS themselves, you can imagine how that is definitely going to be challenging, right? That they come to a service and they feel overwhelmed in lots of different ways. And, you know, how we work in that first encounter can be huge, make a huge difference to being able to engage and support and help them not use alcohol in pregnancy, and not in turn create that sort of intergenerational exposure, right? So yeah, it's a really interesting piece. I'm sorry I can't remember the name of that screening tool. It starts with a C, but anyway, I kept hoping if I talked long enough it would pop back in my head, but obviously it hasn't. But I will, you know, you're welcome to contact me, and I can make sure that you get connected on it.
Sorry, go ahead. I work in the field of developmental cognitive disability, and I'm
Yes.
wondering if you've noticed any connections between, formal connections, I suppose, between the work that you're talking about and the field of disability.
Absolutely, and in this guidebook that I'm working on with the Centre for Addiction and Mental Health in Ontario, there's a group of clinicians from the developmental disability field who talk in one of the chapters about how trauma is different or can be different for people with developmental disabilities, and you know, what does trauma-informed work look like in that context? And you know, just noticing, you know, as we've talked about differences with Aboriginal people, or with women with FAS, or young women, or whatever, people with developmental disabilities may have a whole different experience of trauma, and some of the traumas that they may have are things like losing the death of a caregiver or something, can be, you know, which is not something that we may have thought about as a particular form of trauma, and they may not be able to express, you know, how they feel about it, especially if they have, you know, autism or other developmental disabilities that could affect their ability to communicate as well, right? So you know, I feel like you've asked a very big question that, you know, needs attention, and I think that's exactly the question I was hoping each of us that come to this kind of a session would be thinking. So what's the translation in my context, right? How might trauma be different? What might I need to do about being trauma-informed that might not look exactly the same as a service for in other contexts, right? And really working with the entire staff and the clients to help us understand that. And I know that there's a great group on Vancouver Island in the Cowichan Valley that have done a process called Action for Inclusion, where they've actually engaged young people with FAS and going to different services in their community and helping those services see how they're not, or they might be not helpful to people with FAS. And so it's this process of the people with the issue helping teach the other folks what doesn't feel safe or what doesn't work for them. And I think, we could think about that kind of action for inclusion as a process that could really be helpful in all of our services, including yours, about involving the clients in reflecting on what doesn't feel safe about coming to this service, and giving us ideas for what might work more effectively. And that shines through all of this research, that the people with the problem have a lot to tell us about what that might look like. And we often feel like they don't have the capacity, or they're difficult or uncooperative or whatever, when in fact we just may be not doing, asking in a way that invites involvement and invites difference. So I really encourage you to think about engaging the people you work with and the clients you work with, and thinking through trauma-informed practice in the context of their experiences. And hopefully, in a few years, we'll be able to answer that question with much more evidence. Right now we have a lot of ideas, but we haven't actually studied it, I think, in the ways that would, And I think that's sometimes what prevents us in going forth, is that until we have an amazing study like the Women Co-occurring Disorders and Violence study to show us it helps to be integrated on the issues and it doesn't cost more. Until we have those kinds of pieces of evidence, we often don't shift in our systems. But in fact, we need to create the programs that can be studied and can provide us with more evidence too. So it's kind of that circular piece of, we have to do it and we have to study it, and then we have to share it and continue to evolve our practice based on it.
I just want to make a comment. Christy and I used to be with ADAC and had services for women.
Yes.
And so it's now Alberta Health Services, Addiction and Mental Health. But anyway, we had actually explored that question a few years ago. And I remember seeing Stephanie Covington at a workshop in 2006, and yourself a few years ago had brought up in trauma-informed services. And I remember thinking that it used to feel quite overwhelming, that it was just about regression therapy and and all that kind of stuff. And the more I learned, I found that no, it doesn't have to be that complex. That you can just ask questions about safety, about teaching skills around grounding, and it was, and the women didn't want to go into elaborate stories about their past trauma anyway. That they just wanted to talk that they felt uncomfortable, maybe a little bit about their past trauma, but not in detail, and then just having conversations about, safety around your use, how does that impact your life, violence, that kind of thing. And so it doesn't have to be complex.
I'm really glad you said that, because that's what I was trying to convey around the sexual assault centers thing with the 3 open-ended sessions. Was a lot of the women didn't go on. They didn't want to actually do the deeper work. They wanted the skills and said, thank you very much. And the added impact of that was that the Victoria Women's Sexual Assault Center, by offering those open-ended, all the time, coping skills things, have virtually eliminated their waiting list. Because people aren't waiting for individual counseling or groups or whatever. They're getting immediate support in being able to come to these groups. So it's, it has so many beneficial effects. And in fact, I think the point you've raised is really important to say as well, is that sometimes I feel that in the old ways of trying to establish women's trauma by screening and getting the conversation going, we actually re-traumatize by not creating enough containment and enough safety. And so women started into their whole story of trauma and afterwards didn't necessarily want to have disclosed in that way to you. So in fact, we created less safety and less willingness for her to come back, because suddenly there's this big splat of, oversharing, or in some ways that we created, right? As opposed to creating a kind of a context where we talk about the connections and we help women manage, and contain and ground and all those pieces that you mentioned. Self-soothing was one of the things that they mentioned there. Lots of skills for staying present, and really see our work as very much about those basic things that any of us can do. You don't need a degree in psychology to do. And it's not about exploring a past trauma. You're absolutely right. Although there may be women who do need to do that, and that's great, because we'll be able to see that. When we offer the trauma-informed care, we'll see that there are some women who do need to go to the more intense healing processes, and hopefully we'll have services that can walk that walk with them, but that we've helped women pace themselves. And I think that's what the Jean Tweed Center so clearly said too, was that when we got all proactive about it and said we're going to do trauma and treatment for addictions, that it in fact was destabilizing for some women. That we needed to listen more to the pacing and just say, yeah, these are connected, but you don't have to deal with them all at once, right? That being trauma-informed means that you're acknowledging them, but you're helping with pacing and containment and the process, and helping her decide what's important for her. And in the California thing, women may decide, that they see the violence as the most important piece. They want to go that route, even though they've acknowledged that the substance use may have a connection to it, but there's a sense of that is the most important thing for them. And I guess for me too, that I always want to say, taught well by the Women Abuse Response Program in BC, is that in allowing women the pacing around talking about trauma, we cannot ignore the questions about current experience of interpersonal violence, right? So that while I'm saying, let's not make women disclose about past abuse and that sense of trauma, we cannot in that process miss, are you currently safe in your relationship? Because that trumps it all, right? That is that current experience of woman abuse. And the trauma-informed piece is another lens that lays over that. Remember those 3 circles with the trauma kind of overlaid it at the first. To me, that the trauma is not exactly the same as current violence against women in relationships by any means. We cannot confuse those 2 things. I want to mention the great work of ADAC, if there's not another question in that particular program that you put in place a few years ago around reaching high-risk pregnant women, name of which I'm forgetting momentarily, but the community-based outreach, enhanced services for women, thank you, that ADAC put in place and hopefully is still happening, yay. But the evaluation of that program, I think, really showed the linkages amongst these issues and the importance for women. Initially, I think when we were designing that program, we were thinking about, I actually at one point worked for ADAC, and but I think as we were thinking through those kinds of services, we were thinking that that service was going to help women get connected to Henwood or any of the other more intense treatment services. And I think as time went on, we realized that that community-based outreach that was trauma-informed and built on motivational interviewing and other important strategies was really really important in and of itself, and many of those women were not going to eventually go to formal addictions treatment, that what they wanted was that community-based support. And I remember that one section from the evaluation where the woman said, the client said that she really liked her counselor, the counseling she got from the Enhanced Services for Women program, because her counselor had good ears. And I thought that's such a great way of summing up what trauma-informed care is and good care for high-risk pregnant women, is that idea that we're listening to what they see as important and we're helping them move forth in the steps that they can achieve because we've heard what they're able and willing and wanting to do, as opposed to deciding we've got the list of 40 things that you're going to do, AA every night and going to this test and that test and child welfare appointments and blah, blah, blah. That in fact we're saying what's important and how can we help and where do you want to start.
The conference is about to end.
Big Brother is getting me here. So I'll stop talking, but I so appreciate your attention and your questions and your work, and hope this has been helpful.
Thank you for the great presentation, Nancy. It was a very informative and important discussion, so thank you very much. Please note that evaluations will be emailed to participants within the next 2 business days, so please be sure to sign the attendance sheet if you haven't already. And your feedback on this session is very important to us. And the next session is scheduled for February 23rd at 9 a.m., titled Becoming a Successful Adult Learner.